In the next 15 minutes or so, my job is to talk about the diagnostic approach to osteoporosis. Now, this is a disease which all of you have been associated with. You know that there are diagnostics, there are therapeutics. The therapeutic part, Dr. Bansali will be taking up later. And at the end, if we have some time, we have one case which we could discuss and then have your feedbacks on that. So then, osteoporosis, is defined as a systemic skeletal disease which basically has an abnormality in the bone mass and the bone architecture. Now, both terms are important, remember. Just the fact that someone has a high BMD does not guarantee a good bone architecture. And a very good example for that is skeletal fluorosis. There are some parts of a country where you have a lot of fluorides in the water. Now, these affected people have a tendency to bending of bones, bone pains, and fractures, but if you do their BMD, it's up there. Another molecule which is now no more in routine use was strontium ranelate, and that also did the same thing. It basically increased the BMD fallaciously, but did not produce any big advantage with the fracture. So why do we investigate such patients? The first is, of course, to say that this patient is osteoporotic or not. The second is, and this is very important, to predict which of these patients are going to fracture in the next 10 years or so. And this becomes a very, very important consideration, because this tells us then that this is the patient that requires medication, number one, and what are the medications that can actually potentially prevent a fracture from happening. We also need to know whether there's any underlying treatable or reversible cause, the so-called secondary causes for osteoporosis. We need to know some guidelines that we clinicians need to have as to which patient is a candidate for which kind of treatment. And finally, we need to know whether our medicines are working, and that also requires some investigations. Now, this is, of course, old hat. All of you know what the definition is. A normal bone density is someone who having a bone mineral density within one standard deviation of the mean. Osteopenia is between 1 and 2.5 standard deviation less than the mean. Frank osteoporosis is less than 2.5 standard deviation from the mean. I will presume that all of you were very good in mathematics, and so you all know what standard deviation means. I'm sure all of us became doctors because we were very good at maths. So I'm not going to tell you how to calculate a standard deviation. Just remember that the definition of osteoporosis is less than 2.5 standard deviation of the mean. Severe osteoporosis, on the other hand, is a clinical diagnosis where you need to have osteoporosis, that is less than 2.5 of the standard deviation, plus a fragility fracture. So this becomes then not a statistical diagnosis, but a clinical one. Who do you screen for osteoporosis? There are certain people who would require a screening for osteoporosis, and the first is, of course, advanced age. So if your patient is more than 60 years, then both sexes would probably benefit from some kind of a screening test for osteoporosis. A previous fracture becomes a very, very important consideration. So does long-term glucocorticoid therapy. If your patient is a low body weight patient, less than 58 kgs, then this patient is also more likely to have osteoporosis, and then you need to screen. A parental history of hip fractures, we'll discuss that briefly in a few slides later. Cigarette smoking, current cigarette smoking, as well as previous cigarette smoking. Excess alcohol intake is a risk factor. Moderation, alcohol intake in moderation is actually protective. And we'll see that race and ethnicity is a very important consideration again. Remember that the most robust non-BMD risk factors are age and the existence of a previous fragility fracture. Anyone who has had a fragility fracture is a very, very high-risk patient for having another fragility fracture. History and examination, just like any other disease, is important. Height and weight measurement, a complete examination of the spine. Spine is incidentally a very, very important thing that you need to look at clinically. You need to see for kyphosis, scoliosis, or deformity, localized pain and tenderness. You also need to make the patient stand up and see the gap between the lowest margin of the ribs, the costal margin, and the iliac crest. Now, this is the first thing that actually starts going down in a patient who has had a wedge fracture or a compression fracture. The gap between the rib cage and the iliac crest becomes shorter, and this patient actually loses height. And this is something that you can actually look at clinically. To assess the potential causes of secondary osteoporosis, I am not going to talk about secondary osteoporosis too much today, but you need to have a small checklist at the back of your mind that if your patient has significant osteoporosis, specifically for a patient who you do not expect to have significant osteoporosis, you need to have a checklist where you rule out the secondary causes. The other general examinations to look for any evidence of neoplasms, specifically a breast examination is mandatory for all ladies, and a lymph node palpation. If you do have something suspicious, you need to investigate that organ subsequently. The biochemical examination, the routine examination is something that, just like any other disease, is important. We need a full blood picture and an erythrocyte sedimentation rate. Calcium phosphorus is important, so is the renal function test. You also need to have a liver function test and specifically need to look at albumin. Remember that unless you have that albumin on your charts, you cannot actually interpret a serum calcium level. Urine for Benz-Jones protein is specific for multiple myeloma. You'll be surprised at how many multiple myeloma patients are actually missed up because people were too busy looking at the bones and did not actually look at the possibility of multiple myeloma. Testosterone level in males and estradiol level in females. While diagnosing a postmenopausal lady is easy, sometimes it's actually not very easy to diagnose someone who has undergone a premature andropause, and testosterone level becomes an important test. And X-ray of the spine, which we will discuss subsequently. Now, the optional investigations obviously would be biochemical markers of bone turnover. We'll discuss that in one slide. Urinary free cortisol or the midnight 8 AM serum cortisol if you are suspecting Cushing's. And remember, all of you should be suspecting Cushing's if your patient has unexplained osteoporosis. This is something that you absolutely cannot afford to miss upon. A thyroid function test, I'm sure all you and your referring doctors would already have done the thyroid test before they send this patient to you. Gonadotropin levels, if your patient is having hypogonadism. FSH then gives you an idea as to whether it's a gonadal problem or a pituitary problem, and that also you need to look at. And finally, once you have the calcium and phosphorus on board, also look at the PTH. And so we come to the first radiological examination, and that is an X-ray. If your patient has got a spine problem or a spine pain, he will have undergone the X-ray, and this is a no-brainer. However, remember that an X-ray is not a very sensitive test for a spinal bone mineral density. So your patient needs to have a decrease of at least 1/3 of its BMD to actually for it to show up in an X-ray. The assessment again is subjective. It will depend on how well or poorly the plate has been exposed, and it also depends on the patient's size. A larger patient and a thin-built patient will not have the same kind of radiological interpretation of an X-ray of the spine. Now, what do you see for in a spine X-ray? You look for an increased radiolucency of the vertebra. You see for coarse vertical striations, and that is a sign that the rest of the vertebra is probably losing calcium or mineralization. There is a typical picture frame appearance of the vertebra where the sides of the vertebra show up very well on the X-ray, but the center does not, and it looks like a picture frame. An increased concavity of the vertebral end plates, and this is what in our times used to be called a codfish vertebra. These terms unfortunately are no more in use in medical teaching nowadays, but they are actually very good words. It gives you a word picture and you don't forget that. And protrusion of IV discs. So these are things that you might miss, and your radiologist actually might not report because he is only looking at fractures. So when you have a spine X-ray and the patient says that the X-ray is normal, please look at the X-ray yourself. You might actually pick up one of these things. You now have semi-qualitative assessments of the X-ray, and so there are some rules of grading for vertebral fractures, grade 0 being normal and grade 3 being more than 40% loss in the height of one of the vertebral measurements. This is actually a better way of finding out a fracture vertebra. if actually the vertebra has asymmetrically collapsed, so if you have an anterior versus posterior height which is 30% or 40% different, it's easy to see. But if the entire vertebra has slightly collapsed, it actually becomes a little more difficult to have a semi-qualitative assessment. Additional images like CT, MRI and ultrasound are rarely used. Although MRI is actually very useful to display a sacral stress fracture which cannot be seen otherwise on a plain radiograph, but unless your patient is really very rich, I do not think you will substitute an MRI in place of an X-ray. And so these are there. They can be done if you want some specific area to be looked at, but they are not routinely to be used as an imaging technique. And so we come to the test that actually launched this disease. Do you know that before Listerine was introduced, there was no disease called halitosis? Bad breath was something that was discovered by the Listerine manufacturers. Listerine earlier used to make toilet cleaners and they were not doing very well, and so they decided to make mouth cleaners, and then they started talking about halitosis, bad breath, and then it became a disease, and so there was a treatment for that. Similarly, before you had the bone density measurement, not many people used to talk about osteoporosis. People seldom looked at the bones unless the bone had already fractured. But finally we had something which could actually, before a fracture, measure a bone mineral density, and this actually started this whole new scientific subspecialty. True bone mineral density, that is the density of the bones without looking at the marrow or the other soft tissue, is something that we cannot do. We do not have a test which looks at an area and takes out everything else, including the bone marrow, and only tells you something about the bones. It does not happen. And so we have apparent bone mineral density, which includes the bone as well as the bone marrow. Remember that whenever you are having a report of a DEXA, it is actually looking at the bone marrow as well. And there, the apparent bone mineral density, you can have an aerial bone density. DEXA gives you a per square meter or square centimeter density, not a third dimensional density. You also have the option of a volumetric BMD, which can be done by a three-dimensional quantitative CT. DEXA is generally used to look at the spine and the hip. There are other ways of doing DEXA, which is SPA, SXA, PDXA, or quantitative ultrasound, which we are going to just mention in passing and not dwell too much time on. The dual X-ray absorptiometry is the gold standard for assessing osteoporosis in a patient. This should be measured at both the posterior anterior lumbar spine and the hip in patients undergoing DXA. Remember that the forearm BMD, although it is routinely done as the third site, is not something that you are going to get too much information in terms of post-menopausal osteoporosis. BMD at the forearm, however, should be done if you cannot measure the hip or the spine. In patients with hyperparathyroidism, where the osteoporosis will actually be more in the distal forearm, or in very obese patients where the DEXA table might not cooperate with the patient, and then you might need to put the patient's hand on the table and do this thing. It is an option, but the first options are still the spine and the hip. You can have a pencil beam scanner, which takes about 5 to 10 minutes. A fan beam scanner is much faster. It takes about 10 seconds or so, but it actually gives a larger dose of radiation. The day-to-day variation in measurement is something that is an issue with these machines. So if you have a center who routinely do DEXA scans, make sure that the center actually calibrates their system every day. This calibration is very important. If you want to have a center that is reliable, you need to make sure that they calibrate their systems every day. Reporting, as you all know, is by a T-score and a Z-score. T-score is the number of standard deviation above or below the mean for young adults at 30 years of age. This is a specific number because irrespective of the age of the patient, It is compared against a young adult mean, and this is the basis for diagnosing a patient as having osteoporosis. We have already discussed that. These machines also give you a Z-score, which is actually in comparison with other people of the same age group. Now, obviously, if you have a very elderly patient, 80, 90 years of age, even a so-called normal person will still have a very low T-score because you're comparing her against a 30-year-old. And so, in certain conditions, as we'll see, the Z-score can actually be used for diagnosis or assessment. For monitoring changes in BMD, remember that you need to have a test which actually can differentiate between the first test and the second test. And this difference, a machine can only give you a significant difference between two tests if you have a 3% change of BMD at the spine or 5 to 6% at the femoral neck. And this is the reason why you do not ask for repeat BMDs every 2 months. No matter what you are giving your patient in terms of therapy, do not expect any change in the DEXA scan reports before 1 year at least, because you need at least a 3 to 6% difference from the first scan to the second. For obvious reasons, you do not ask for a DEXA scan in pregnancy. Remember, it's an X-ray based treatment. Recent administration of oral contrast media or radioisotopes, spinal deformities, then the machine cannot actually pick up the exact density of the spine, and orthopedic hardware. If the patient already has an implanted orthopedic device, you cannot ask this patient to undergo a DEXA. Who should be screened? The recent Osteoporosis Foundation guideline says that all women more than 65 and all men more than 70 actually should be screened for osteoporosis. In women who are between 50 and 70, if they have other clinical risks, should also be screened. Remember, it is not recommended for children and adolescents, and it is not routinely indicated for healthy young men or premenopausal women. How many of you get a patient who already has had a DEXA and comes to you with a report and asks you to comment on, she's 22 years old, she had some vague back pain, and she had been asked to do a DEXA? Do not even look at the report, because this is not a time when the patient has yet achieved her peak adult bone mass. Remember that the peak adult bone mass comes at around 30 years. If your patient is 22, obviously her density will be less than what you are comparing it against. It is a fallacious reading, do not do it. Even if the patient comes with the report, do not look at it. At least do not take any action on the reports. The limitations: measurement at spine in 65 years is difficult due to osteoarthritis and calcifications. Accuracy is reduced in the obese individuals. It's very difficult to do this test in the obese. The rate of change, as we discussed, is not so quick. Do not even ask for a repeat test between 1 or 2 years after you have started treatment. There's a very high variation rates for these repeat measurements. And remember to send the patient to the same center and preferably the same person to do the test. Now, these are other uses of a DEXA machine. You can have a vertebral fracture assessment. I'm just going to go through these slides. They are not very important. Trabecular bone score. These things can be done using the same machine with different softwares. Now, a trabecular bone score basically tells you about the architecture of the bone. So, two people having the same DEXA T-score can actually have a different trabecular architecture, and this TBS can actually predict fractures. This patient obviously will have a much less risk for fractures than this patient, although both these patients' BMD will look the same on a DEXA scan. What if you do not or cannot have the DEXA scan? We have the FRAX score. In fact, the FRAX score was introduced specifically for countries who did not have the infrastructure or the cost-bearing capacity of having DEXA for all their patients. And this is what the FRAX score questionnaire looks like. The important things I'll just draw your attention to: ethnicity is a very important question in this. Age, sex, weight, height, previous fractures, parents fracture hip. If your parents have a hip fracture, then you have to put yes here. They are all yes-no kind of a questionnaire, as you can see. Current smoking, glucocorticoids, secondary osteoporosis, alcohol 3 or more times per day, femoral leg. If you have the BMD, you put the BMD value, but it's not mandatory. FRAX can be done even when your patient has not undergone a fracas. Now, if your patient is Susie Smith, a lady, a US Caucasian, and has no to all her questions here, then the chances of osteoporotic fracture is 11, hip fracture is 2. However, any yes immediately causes the chances to go up from 11 to 21 and from 2 to 2.1. If the patient already has a previous fracture, then it goes from 11 to 19, 2 to 3.5. And so this is something that can theoretically replace the need for DEXA. All of your patients in all the parts of our country cannot actually have access to DEXA, and FRAX becomes a very important screening tool for such patients for predicting fractures later on. Again, these are tests that are there. You need to know about it, just so that you know, oh, yeah, I know about quantitative computer tomography. Incidentally, the QCT is actually a very, very good test for microarchitecture of the bones. It actually can give you a very, very good this thing of which patients will undergo fractures. It does not have the problem of osteophytes, which DEXA has. The disadvantage, obviously, it's much higher radiation dose and much higher cost than your DEXA. The ultrasound of the calcaneum at one time used to be a very popular test. At this point of time, it is only mentioned as a screening tool. It is not a diagnostic tool anymore. So if you want to have a population-based screening, you can do a calcaneal ultrasound. The obvious disadvantage with this is it does not look at the osteoporotically important areas of your anatomy. Calcaneum is hardly an area where you will have significant osteoporotic changes. MRI imaging is actually very good. It can pick up, as we discussed, occult stress fractures of the proximal femur, which otherwise cannot be picked up by anything else. Biochemical markers are only to be mentioned. These are not recommended for diagnostic workup in patients. These are more for prognostication for a patient. So you do not make a diagnosis of osteoporosis based on biochemical markers. You have formation markers, which are all blood tests, or resorption markers, which can be blood tests or urine tests. For the sake of time, I'm just going to skip this slide. Just remember that they are there. They are only used for assessing of bone loss. If a patient has a sharp increase in the biochemical markers, then these patients are going to fracture much earlier than the others. If the patient has a fast loser, then also the biochemical markers will be high, and these patients have a higher risk for fractures. But most importantly, the bone markers are better used for following up a patient after starting a treatment. Remember that a DEXA cannot be done within 1 or 2 years after starting therapy. So how do you know that your patient is improving? The bone markers, the turnover markers can be a very good test. Bone biopsy is generally not required. It is more of a diagnostic tool, an academic tool. In children and adolescents, we have discussed that it is not routinely indicated that they should undergo DEXA. And that is my last slide. The important thing about the diagnosis in this population must be based on a low bone mineral content or BMD in conjunction with a clinically significant fracture history. A clinically significant fracture is a lower extremity long bone fracture or a vertebral compressor fracture or 2 or more upper extremity long bone fractures. It is not very common that we'll see these patients in our clinic. I think I will stop here because, yeah, my time is also up.